Okay, good morning. Thank you. So the title of my talk was originally supposed to be about the ACCLAIM trial. That's what you'll see in the brochure. But unfortunately, the ACCLAIM trial has not concluded recruitment, and so we kind of modified the talk a little bit. So we're going to kind of give an update in treatment of colorectal liver metastasis, current and past trials, kind of keeping a focus on what the ACCLAIM trial was about. So let's just start real quick about colon cancer. It's the third most common malignancy worldwide and the third leading cause of cancer-related death behind lung cancer and prostate cancer, as you can see here. Over the past few decades, there have been many advances in treatment, specifically systemic treatment, so cytotoxic chemotherapy, immunotherapy, targeted therapies, as you can see here with an increased number of therapies. However, despite these advances, patients with metastatic colorectal cancer have dismal overall survival rates. We know that colorectal liver metastasis in particular are seen in greater than 50% of patients with colon cancer. When we think about metastatic cancer, for example, colon cancer, you have metastatic disease to the liver, that would be stage 4 disease, advanced disease. However, over the past decade, a little bit longer, there has been this new stage of disease, the intermediate stage, specifically with colorectal cancer. And this is for patients with oligometastatic disease. So they have disease isolated to the liver and nowhere else, so no extrahepatic disease. It is for patients with 1 to 6 intrahepatic metastases. And what we've seen, many studies have shown that a multidisciplinary approach to treatment of these patients, because of the improved liver-directed and combination therapies, actually has resulted in improved median overall survival times, reported to be greater than 5 years. So there's been a really big focus on this intermediate stage or oligometastatic stage with colorectal cancer. When we talk about treatment of these patients, there are many treatments for patients with colorectal or this intermediate stage, liver-directed therapies. We know these patients get surgery, whether it's resection and now liver transplantation. We can do hepatic artery infusion pumps, so surgical catheter ablations, whether they're heat-based, RF, microwave, now histotripsy, even cryoablation. Of course, our embolic intra-arterial radiation, and then systemic therapy. So there's many treatment options, which is why we're seeing improved survival in so many trials in these patients these days. However, the gold standard remains to be surgical resection. As you can see from this diagram, there's many different resections. You can do segmentectomy, hepatectomy, extended right or left hepatectomy. If you see in this diagram, all of these surgeries are anatomic. We're not, other than the wedge resection, the first one where you're removing just the lesion. They're all anatomic surgeries. So larger volumes of parenchyma are being resected. In this one study, it showed that liver resection in particular has improved 5 and 10-year survival rates in patients. So the green box here is patients with metastatic disease without treatment other than systemic treatment, and the blue boxes are those who have resection in addition to systemic. And you can see significant survival improvements in these patients. However, despite surgical resection being the quote-unquote gold standard, less than 20% of patients are eligible for resection at diagnosis, often because of their underlying performance status, the extent of disease, the location of the tumor. And then, as I said on the last slide, the complex anatomy, the location of the tumor, these limit how you can do resection, often resulting in these large anatomic resections because you can see all the vascular supply, the bile ducts, etc. And the more liver you take, the less remnant liver you have, and the increased morbidity you have. So then there's been this push to look at parenchymal sparing resection. And so there's been many trials on this showing decreased morbidity and mortality when you do small focused resections. So you have a very minimal margin of normal tumor. Your resection margin is very small, and as compared to the anatomic resections. And what these studies have shown is your local control and survival benefits are equivalent between the two groups. So when we look at this one study, here what you can see, this is overall survival in this patients with parenchymal surgical resection, which had an overall survival rate of 48% at 5 years, versus patients with an anatomical or non-parenchymal sparing resection, where your survival rate was 39%. So while this was not statistically significant, there was no real difference in your outcomes, but there was a significant decrease in the morbidity post-treatment. Another study, which was a meta-analysis, looked at multiple studies that were released on parenchymal sparing versus non-parenchymal sparing. And again, the conclusion from this is that there is really no overall difference in terms of parenchymal sparing and large anatomical resections. So the take home from these studies is that there's a trend towards minimally invasive treatment, which brings us to ablation now. So there's increasing evidence then that you've got improved safety profile, lower cost, and shorter hospital stays when patients get thermal ablation of their colorectal liver metastasis, with similar local control and overall survival, specifically in lesions that are less than 3 centimeters in size for patients with this oligometastatic intermediate stage disease, compared to those getting surgical resection. In addition, of course, when you're just doing microwave ablation, it satisfies that concept of parenchymal sparing surgery, which I just spoke about in the last couple of slides. So that brings us then to now trials comparing ablation to surgical resection, which is what the ACCLAIM trial was, but unfortunately we don't have that data. So let's kind of walk through some data now of ablation versus resection, or just ablation for these colorectal cancer patients. So the CLOCK trial, this is a randomized phase 2 trial looking at local treatment of unresectable colorectal liver metastasis. So this did not compare ablation to resection, but what it did was compare standard of care systemic therapy to the addition of ablation to systemic therapy. So many of these patients are getting their systemic therapy, and then when they have these liver mets, we have the control group where we're doing no liver-directed therapy, and then our experimental group where we are doing the liver-directed therapy. And what you can see here from these two curves is that thermal ablation improved overall survival at both 5 and 8 years, which was statistically significant. And the improved kind of survival was 43% when you added ablation, as opposed to 30% at 5 years, and then at 8 years, 36% with the addition of ablation, as compared to 9% in the control group. And the second graph, which is progression-free survival, also shows statistically significant improvement in PFS in the patients who had the addition of thermal ablation. Which leads us to the next trial. This is the MAVERICK trial. This trial perhaps provided the strongest evidence for ablation. It was a multi-center prospective trial evaluating survival after microwave ablation versus resection. The patients had to have less than 5 intrahepatic metastases. Each met has to be less than 3 centimeters in size, no evidence of extrahepatic disease, and each of these tumors that they had to be eligible for either resection or ablation. And then they randomized the patients. They prospectively, this is not randomization, I'm sorry, they prospectively accumulated enrolled patients for the microwave ablation arm, and then they used cohort study for the surgical resection. And once they went through, the final number of patients enrolled for thermal ablation was 98 and 150 who went surgical resection. So what do the results show then? As you can see from this data here, the survival rates shows no significant difference between the two cohorts, microwave ablation versus resection. When you look at our 3 and 5 year data, again, you can see very similar survival data at both those time points for resection versus ablation. In addition, the overall complication rate and major complication rate in this cohort of patients was less after ablation compared to surgical resection. And remember, these are parenchymal sparing resections, so these aren't the large anatomic resections. So very similar in terms of volume of liver that's being treated. Significant decrease in complications, 67 and 80%. So that is a drastic reduction in complications when you look at ablation versus resection. The one area where microwave fared poorly was there was a higher rate of local recurrence. So we're not talking about survival, but local recurrence. So hepatic retreatments were more frequent after ablation. The conclusion of this trial then is that there's strong support for using ablation as an alternative for curative treatment of patients with small, remember less than 3 centimeter colorectal liver metastasis. This then led to the COLLISION trial, and this is probably most comparative to what the current ACCLAIM trial is. And this is a randomized control study. It's a phase 3 non-inferiority trial comparing ablation to resection, again, for metastatic liver lesions less than 3 centimeters. So non-inferiority meaning really we're just showing that one is not better than the other. We're not trying to prove one is better than the other. The primary objective, as I said, non-inferiority, ablation versus resection in small lesions without extrahepatic disease. The primary endpoint for the COLLISION trial was overall survival, with multiple secondary endpoints, of course, overall disease-free survival, time to local progression, time to distant progression. They looked at procedural morbidity, mortality, lengths of hospital stays after resection versus ablation, pain and quality of life surveys as well. So the COLLISION trial, what exactly was it? So the patients had to have at least one tumor that was less than 3 centimeters in size in the liver. This tumor had to be suitable for resection or ablation, but they could have up to 10 lesions. So when you look at the way the study was designed, 10 lesions is a lot, and now you're out of that intermediate stage oligometastatic population. So I think this is one big limitation of this study. Again, no extrahepatic disease. Once patients were pre-selected, an expert panel decided if they were eligible for the trial. And so there was a few different categories. The low disease burden, they had 1 to 3 lesions. The lesions could be either resected or ablated. And then you had an intermediate and high disease burden as well. So specifically with the low disease burden, if they were suitable for resection or ablation, they were then randomized. The other limitation of this study is that these intermediate and high disease burden patients were also part of both groups, both cohorts. So I think that really confounds the data, and we'll get into that. So you had the resection arm, which was arm A, and that was the control arm. So these patients who had multifocal disease, the target lesion, the one that was randomized, was part of the trial, but these additional lesions that they had, anywhere from 2 to 10 additional or 2 to 9 additional lesions, were also treated. So these patients sometimes had simultaneous resection and ablation, or ablation and resection. Arm B was the ablation arm, but they may have had resection as well. Very confusing, I think, the data. And there was 148 patients in each group. The results, however, when we kind of parse all of that confusion with the inclusion criteria in, show a couple things. It shows that local control per tumor and per patient, so the first 2 lines here, have very low hazard ratios, 0.09 and 0.13 for the ablation group, meaning that there is very low risk of local recurrence in these patients. And then when we look at overall survival, the hazard ratio is 1.05, meaning that really there's no difference between ablation and resection in these patients. Therefore, because there was non-inferiority demonstrated so early in this patient population, the trial was stopped before completion, because it shows that ablation and resection are almost identical in these patient groups. So looking at the Kaplan-Meier curve, then when we look here, again, this shows the same hazard ratio. It's just a different way of showing the data. It's showing now the overall survival is really not different between the two cohorts. And distance, progression-free survival also is very similar between the ablation and resection groups. When we look at the long-term results, so even though the trial was prematurely ended, those patients that they had treated or that had enrolled into the trial, 5-year overall survival, you see 51 versus 58% between the two groups, so no statistically significant difference. There was a lower complication rate in the ablation group compared to the resection group. And when they performed subgroup analysis looking at the tumor hepatic load, the number of lesions, age, other comorbidities, et cetera, there was no statistically significant difference. I already told you kind of some of the limitations. A high rate of combined ablation resection kind of muddies the results. High rate of missing data, so when they're looking at the data over long term, there's a lot of data points that were missing. And then even though they say up to 10 lesions that you could have had, most patients had less than 5 lesions. Actually, the median number that was treated was 2 lesions, and so really you want to be cautious when you apply this data to patients with extensive hepatic disease burden. You don't really want to use this data for those patients because they may not have as good of outcomes. A lot of words here. What I want to focus on is what's in yellow. Again, the results here: reduced morbidity and mortality. The treatment-related mortality, again, was almost 0 for ablation. 90-day mortality, very low for ablation as compared to resection. And then your complication, your AEs and SAEs, again, 56 and 20% for resection, and then 19 and 7 for ablation. So the complication rates are much lower after ablation. And then a quick slide then on what is the ACCLAIM trial, since that was what this talk was supposed to be. The purpose of the ACCLAIM trial, it kind of, I started with, all these trials went into the MAVERICK, the Collision, and now the ACCLAIM trial, basically demonstrating that microwave ablation of up to 3 lesions, so still in that intermediate stage oligometastatic patient that we see with colorectal disease, maximum diameter less than 2.5 centimeters, results in a 2-year local progression-free survival of at least 90%. It's a multi-center prospective standard of care trial, and the hypothesis basically is that microwave of these lesions with an ablation margin of at least 5 millimeters will give you local cure, so definitive local tumor control with minimal morbidity. It's an international study. The goal is to enroll 330 tumors in patients with 1 to 3 metastatic lesions using microwave ablation. Really, they don't care what device you use. You can use any FDA-approved microwave ablation device, and your ablation margins should be minimum 5 up to 10 millimeters in diameter for your normal hepatic parenchyma that you're treating surrounding the liver tumor. One of my last slides, I'm just showing here, again, why we're talking about oligometastatic or this intermediate stage disease is because there's been so much new research and so much new data on this minimally invasive liver-directed therapy in this cohort with significantly improved outcomes in these patients. So where we used to lump these patients all in the stage 4 disease, advanced stage, we now have parse them out into this intermediate stage showing significantly improved outcomes. There are multiple treatment options, as I showed you in the beginning of this talk, and here I just outlined a few of the trials. What I want to highlight is the outcomes here. You can see that all forms of these therapies, the hepatic artery infusion pump using TACE, TARE, SBRT, you're seeing improved PFS and similar to improved OS when compared to your standard of care resection. So in conclusion, management of colorectal liver metastasis is continuously evolving with a shift towards minimally invasive interventional tissue-preserving approaches. The major focus is investigating non-inferiority in overall survival for microwave ablation versus resection for curative intent. The key results from most of the trials which I've showed you is that treating small, less than 3 centimeter metastatic lesions with microwave yields comparable OS, overall survival, to resection with significant reduction in treatment-related morbidity. In addition, a combination of resection and ablation also improves outcomes. Remember, we're still using systemic therapy in many of these patients, especially those with a high burden of metastatic disease. Thank you.
Thank you, Dr. Michelle. The session is now open for questions. Please, ma'am.
Yeah, any questions, please? Want to comment?
In one of the studies, the first one, you said that systemic therapy versus systemic with the microwave ablation. So those patients were already outside the radio frequency ablation zone. Okay, they are not typical patients.
Those patients were not resection candidates.
Okay.
Yeah.
They were not
So
resection.
they added ablation to them.
Okay.
Yeah.
My question is actually beyond this trial and all I'm asking, because now cryoablation in vogue, so do you think that, it will take over microwave, or it's
For
the patient's choice?
cryoablation specifically?
Yeah.
I don't think cryo will take over. I still think that we're using microwave ablation way more than cryoablation. It's easier to use. I think the data for liver microwave is still better than
Yes.
cryo. Yeah, I think there might be certain instances, high dome lesions near the diaphragm or central lesions by the hilum where thermal injury precludes ablation, and so you may use cryo instead.
Also, this trial has, all treated less than 2.5 centimeters. So this is also beyond this question, is beyond this trial. Said, we used to do a lot of RFA. So, we had needles which were, umbrella open, and we could ablate 6 centimeters or something, especially in, our country where the patient presents a little later with a larger tumor. So you think that will also get obsolete because of microwave, and you can place multiple antennas?
I mean, you can do multiple antennas. I think the data still, even though you're saying, with RF, you're treating bigger lesions, I think all the data, when you look, even Eastern and Western population data, is still ablation, thermal ablation. When you do thermal ablation, the purpose is a curative intent, right? You compare it to surgical resection. So at least for HCC and cirrhotic patients, that 3 centimeter number is that magic number where your 5-year data is equivalent to surgical resection. So I think the same holds true probably for colorectal as well. And I think with any thermal ablative modality, your limitation is going to be the heat sink effect and being able to continue to treat out. Because once you get necrosis centrally, your propagation of heat becomes limited. So I think when we talk about this, the purpose, if we're talking about, is curative intent and having non-inferiority for any of these trials to surgical resection, and you want to get a resection margin of at least, 5 to 10 millimeters, like an RO resection, then you want to treat tumors less than 3 centimeters to have the similar cure rates.
Thank you. Any other questions?
I have a question. With now SBRT coming up in a lot of trials, so even for HCCs as well as colorectal metastasis, if you have a central lesion or it's a subdiaphragmatic, okay, we have a limitation, so we send it for SBRT. But for peripheral lesions with the same less than 3 centimeter criteria, how do you discuss in your MDT team whether it goes for ablation or SBRT?
Very good question, and I think that holds true for whether it's a metastatic lesion or an HCC, right? When we present these cases, I always say the choice of treatment for liver-directed therapy depends on who's sitting at tumor board. So if your interventional radiologist is not there that day, then the peripheral lesion's going to radiation oncology for SBRT, right?
Oh, yeah.
I don't know. I mean,
Otherwise,
out
from your
of
experience,
Toronto,
like,
I mean, there's a lot of studies out of University of Michigan with SBRT of liver disease, and when you look at small tumors, again, less than 3 centimeters in size, the local controlled data is equivalent, if not better, with SBRT. So I think with ablation, One of the limitations is there's a lot of user limitation, right? Are you getting good enough ablation zone size? Did you place your needle properly? Are you interpreting your post-treatment imaging properly? Whereas with SBRT, it's a little easier. And of course, you're using high doses, minimum 50 grays, I think, in some of these patients. So I think if you actually, there's no comparative SBRT RF trials. If you look at it, it's all retrospective data forming these big studies, comparative studies. So I think we just need more trials comparing, like prospective trials comparing SBRT to ablation, to thermal
And,
ablation to see which one's better.
My question is not related to that, but if it is a subdiaphragmatic lesions, like which is not ablatable, how do you decide between radiation segmentectomy versus SBRT? Again, the same.
Yeah, no, that's another good question. I think, again, it's still who's sitting at the table. And I can tell you, for our tumor boards, we have those discussions as well. And I think what we look at is size of tumor for us at least. If it's a little bit bigger, over that 3 centimeter, we'll go towards Y90
Yeah.
as
I mean,
like
how
a
do you
radiation
decide,
segmentectomy.
Okay.
Based on legacy trial,
Yeah,
right?
legacy,
Although
yeah.
legacy is not for colorectal, but now we're starting to see some Y90 colorectal trials that are starting to emerge. But based on the legacy data is kind of what we are using for that.
Sure. Thank you.
Yeah. I would say though now with the new Y90 data that's so robust, what I'm seeing at our institution and even other institutions and in the literature is there's a trend towards Y90 as opposed to SBRT now.
Well, I missed most of the talk because I was busy, but really it is very upcoming, particularly in view of a non-inferiority trial. You can deliver the same results by a much less invasive procedure, and the ultimate outcomes are the same. I wanted to make just 2 quick comments, and one was regarding the radiation therapy. As far as radiation is concerned, if you need to give radiation properly and only to the target area, you still need to place the fiducials, so it becomes invasive anyway. It's not that it is totally non-invasive. And at the same time, there is always a risk of radiation-induced liver disease. So in my personal opinion, as well as the literature says that radiation will not be really a match to ablative therapies if it comes to lesions, metastatic lesions in the liver. Now, talking of different ablation modalities, which are all thermal ablation modalities, before I come to that, the point I'm trying to make is that we are entering an era of immunotherapy. Many of these patients will be at some point in time be subjected to some kind of immune checkpoint inhibitors. Now, which of the ablation modalities works best to present the cancer antigens for a better effect of the immunotherapy? That is, it has been established that is cryoablation. Cryo doesn't destroy the cancer antigen completely. It is actually freezing the antigen, and that is some results have come out already that the results of immunotherapy are far better if the antigens have been released by cryo and not by RFA or microwave. So the future lies in combining therapies, ablation plus immunotherapy, IO plus IO, immuno-oncology and interventional oncology.
Yeah, I completely agree with that. And on Sunday, I have a talk on histotripsy, where the antigen presenting capability of histotripsy is even more robust than, some of these other trials. So I do think, I agree, the combination therapy is kind of where the future of oncology care will be.
Okay.
Thank you.
Thank you, Dr. Michelle, for the thought-provoking lecture. And we'll move on to the next session.
I would like to thank the chairpersons for their valuable inputs. Thank you, ma'am. Thank you, Dr. Michelle, for a very informative talk. You didn't just speak about the ACCLAIM trial, but a few various other trials which were very practically useful. Thank you, ma'am.